Hi everyone, so today we're going to cover acid-fast bacteria in Chapter 5. The chapter is fairly short and it only really focuses on just a few of the organisms that you can find that are acid-fast. So I'm going to go a little bit more into detail on a few of these, but for the most part what the book has is good enough for what you guys need to know. Objectives you guys can read on your own. And just to kind of give you a reminder, here we have a picture of our gram-negative and our gram-positive cell wall, and then also in comparison to our acid-fast cell wall. And the major difference here is that the acid-fast cell wall normally has mycolic acid, which is rich in lipids, which makes it harder for regular stains to penetrate. So that's why we need those other the acid-fast stain to be able to visualize mycobacteria or other acid-fast bacteria. So general characteristics for your mycobacteria is that they are aerobic, they grow intracellularly, they are non-spore forming, non-motile, usually thin, slightly curved or straight rods, grow very, very slowly. Now some do grow a lot faster than others, but the ones that are usually pathogenic for us that we're going to be discussing today are slow growers. Media that we use to grow these is your Middlebrook agar and your Lowenstein-Jensen agar. And again, acid-fast cell wall with a very high lipid content. Pathogenesis and disease. So you get this by, you can even be infected by inhaling just a single organism. Usually people who are more susceptible are the ones who are immunocompromised. Your PPD test is the one that detects to see if you have infection. And M. bovis. M. bovis is one that's associated with the ingestion of milk from infected cows. But this is where the BCG vaccine comes from. So an attenuated version of the M. bovis organism is used to immunize people against tuberculosis. Tuberculosis can usually mimic other diseases. The clinical manifestations can range from being asymptomatic to being acutely symptomatic. Symptoms then include usually just your regular, low-grade fever. You can get night sweats, fatigue, anorexia, weight loss, and then you have a productive cough. So upon infection, what happens is that your T cells and macrophages migrate to the lungs, and then the macrophage wants to phagocytize the organism. However, because of that cell wall, microbacteria are able to grow intracellularly. So therefore, the host is then unable to eliminate the organism. Some may be destroyed. Some could form a granuloma. And then the ones that kind of stay behind after they have not been destroyed are the ones that kind of cause that systemic hypersensitivity or systemic problems later on. Tissue necrosis may result if antigen concentration is high. The disease may spread through the lymphatic system or through the blood. And that's when you end up getting what they call disseminated tuberculosis because it has now spread. And then again, patients with a depressed immune system are more susceptible. So the other organs that could be involved after infection and after it's already kind of done its thing, it's grown, it's survived the normal immune process, and it is now spread, and it can spread, pretty much anywhere. Patients who don't have any symptoms are, we described as having latent disease. They don't have any apparent signs or symptoms. Usually they're not infectious at this point, but however, they can progress to having active disease. And usually the reactivation occurs if there's some kind of incident that happens, so damage or suppressed cellular immunity. Screening, you guys are all pretty much familiar with the PPD test. They also have a spot test, and then the most, something that's been gaining more popularity now is the quantiferon gold test, which is a blood test. Mycobacterium avium complex, the book kind of touches on this slightly. It includes a whole bunch of other non-tuberculous mycobacteria. Again, the incidence of these are higher in patients who are immunocompromised. These are the ones that usually cause some type of respiratory disease, lymphoadenitis in children. And usually the main ones that are found are your M. avium and your M. intracellular. But there's a whole bunch of other ones that they haven't listed here, and that's okay. You don't need to know that right now. Leprosy, also called Hansen's disease, is caused by Mycobacterium leprae. It is a chronic disease of the skin, mucous membranes, and nerve tissue. And again, the bacilli multiply in the peripheral nerves and cause sensory impairment. This organism is not cultivatable in vitro, so meaning we cannot grow this in the lab. They do grow it. I guess it can be cultivated on armadillo or mice footpads. However, we don't do that. Usually we just use PCR assays or some type of, instrument or whatever to identify it. Diagnosis is also based on the clinical manifestations and then, of course, the positive acid-fast stain from a skin smear. Again, this is transmitted person to person. There are two phases. You've got the silent phase where the bacilli multiply in the skin's macrophages. Then you've got the intermediated phase where the bacilli multiply on the nerves, and that's when it begins to cause sensory impairment. So they have two forms, a tuberculoid form and a lepromatous form. And the difference between these is that the tuberculoid form is usually localized to skin and nerves, where lepromatous disseminates. This is where you have your extensive skin lesions and lots of acid-fast bacilli, whereas with the tuberculoid version, it's again localized and you'll usually only find a few organisms. The CDC recommends a biosafety level 2 area when we are dealing with regular smears and cultures of non-aerosol cultures. If we are opening centrifuge vials, however, or adding reagents or setting up molecular tests, they require to use a biosafety level 3. So what that means for us is usually in the hospital, if we receive a sample, the most we will do with it is a gram stain or maybe even an acid-fast stain. After that, if the acid-fast stain is positive, we will usually send it out to a laboratory, a reference lab, where they have higher biosafety level practices. Specimen collection and transportation. Usually specimens are processed within the hour. If processing is delayed, then specimens should be refrigerated. And then specimens can include pulmonary specimens, gastric lavage, urine, fecal, tissue, body fluid, so on and so forth. Usually, for the most part, what you'll see are sputum specimens. Direct detection. So here we go with the different stains. So you have your fluorochrome, your Zeal-Nielsen, and your Quignon stain. And basically what you need to remember between these is your fluorochrome are the ones that fluoresce. Your Zeal-Nielsen uses heat, and then your Quignon is done without heat, or what we call cold. So to remember that Quignon cold kind of has the same beginning sound, and then therefore your Zeal-Nielsen is your hot, or has an H in it if you want to remember it that way. And then of course your fluorochrome requires some kind of a fluorochrome. There are other ways too. We've got antigen protein detection, immunodiagnostic testing. You can do genetic sequencing and nucleic acid amplification, DNA microarrays, and MALDI-TOF. And then here you just have a picture of the two different stains. So you've got, the bottom one is your Zeal-Nielsen, which is hot. The Kinyan is basically the same thing, except you don't use heat. And then the top image here is that of a fluorochrome stain. Drugs that we use against Mycobacterium tuberculosis, usually it's streptomycin, I don't know how to pronounce that, but here you go. Here you have a list. But these are the primary drugs that they use first. Some mycobacteria are now becoming even more resistant to drugs, so therefore they have some secondary drugs that they use. From what I was reading, usually the last one is the one that they use more often than not when it comes to having to use something besides the primary drugs. Prevention, so you've got the BCG vaccine, and they are also working on some other vaccines, but it's still experimental. And that's it for your mycobacteria. So moving on to nocardia. So nocardia, again, is also acid fast. It's actually weekly acid fast. It's also aerobic, also grows intracellularly, also non-spore forming and non-modal. Something that stands out with these is that they show right-angled branching or have a faint beaded appearance with alternating positive and negative areas. And that's due to it being weakly acid fast. So some of the stain can get through, but not all of it. Another thing about nocardia is that it's sometimes mistaken for fungi. And the fact that it grows on sabro-dextrose agar is another reason why it can be mistaken for fungi, because that's something that we normally use to grow our mycology specimens. Other media that we use is your buffered charcoal yeast, medium using paraffin, Martin Lewis is sometimes used, and then CNA is what they say is gives you optimal recovery. But again, it's a slow-growing organism, so it's going to take a while. Again, nocardia is usually found in individuals who are immunocompetent or immunocompromised. You've got 4 or 5 things that they list in the book, which is your bronchopulmonary disease, mycotomas, lymphocutaneous infections, skin abscess, cellulitis, or even brain abscess. So that's something that you guys want to make sure you look into. The virulence factors include, usually it depends on the stage of growth. They have resistance to intracellular killing, the ability to inhibit that phagosome-lysosome fusion, and the production of large amounts of catalase and hemolysins. Other partially acid-fast bacteria that were kind of mentioned in the book are your Rhodococcus. The other 2 they didn't mention in the book, and then the other one is Tsuka morella. The one thing that you need to know about the Rhodococcus is that it's often dismissed as diphtheroids. Again, because they're partially acid-fast, sometimes they can be seen on gram stain, and they will look like diphtheroids on gram stain. This kind of just summarizes what I just said, but basically, nocardia are partially acid-fast. They have an unusual long chain fatty acid in the cell wall, so again, that lipid-rich cell wall. The organism retains carbofuchsin dye during mild acid decoloration, and usually will show reddish to purple filaments. And that is it.